Our next speaker is Dr. David Livingston. He's a professor of surgery and division chief of trauma and critical care at Rutgers. He did his surgical training at NYU and his fellowship at Louisville. He's going to talk to us about the ABCs of pan scanning. Dr. Livingston.
Let's see if it comes over now. Okay. Well, thank you very much, and I want to thank Peter and Dave Nitrica for inviting me. Anytime you can leave the Northeast in the fall and winter and come to Arizona, that's not a bad thing. Also, I guess, I'll probably, someone will Google this and I'll be proven wrong, but I think it was W.C. Fields said it shouldn't work with animals or children. In the trauma and conference game, you should never be the last speaker that's between you and lunch, okay? So I'm going to try to make this enjoyable, and so maybe you won't, and try to keep your stomach from rumbling too badly. I have nothing to disclose, except I really wish I owned a CT scanner. I really do. You know, I wouldn't be up here. I would have that resort down the block or something like that. The goals of this talk are really to try to put some definition into this whole argument of pan scanning and selective imaging, and what are we really talking about, and what images are we talking about, and what image are we trying to get, and a bunch of things. And really you can divide it up into the head and cervical spine, and then chest, abdomen, and pelvis, and maybe what about the spine, and really going to concentrate mostly on the chest and abdomen. I think that the first two, are fairly well defined, although we'll talk about them as well. I'm also going to try to add some science to this instead of opinion. I know science has been ruining everything since the world is not flat and we're not the center of the universe, but you never know, okay? You can probably put global warming in there too as far as science and things like that, all right? And remember, ABC in this day and age is not arrive, begin, CAT scanning. Okay? Although you would think that would be the way it goes in most ERs right now. I don't think I've operated on an appendix in the last several years that didn't have a CAT scan. You know, when I trained, my COPES had no CAT scanning in it. That just proves I'm old. But still, I think that there is, whatever. It's just the way it is. You also, when you're looking for something, you need to understand what your goal is. Now, this gentleman's goal is really conflicted, because if he moves, he'll get shot by the guys who are deserting him, but if he moves, he may get shot by the guys who are trying to do target practice. So again, you need to set your goals in what you are actually trying to achieve with your imaging of the trauma patient. And again, if you lose sight of your goals, you kind of do some funny things. And I think that's a really take-home message in all of care. And really the goals of trauma care acutely, in the acute setting, is to control the airway, to stop bleeding, and again, we talked about that this morning, that's why people die, right? And then to quickly identify life-threatening and then even life-debilitating injuries within the first 30 minutes, okay, the case that Dr. Ree articulated, if you can't get to the problem, that's a problem by itself. And none of these require advanced imaging. None of these. Okay? And really, advanced imaging comes in the second phase of ATLS and the second phase of everything. And usually, you want to get there right at about 30 minutes, okay? Because advanced imaging shouldn't be delayed as well. But it's not what's going to keep your patient alive or not alive. And we all know that death can begin in X-ray. Right, here's your X-ray tech, all right, ready to put the patient on the CT scanner, all right? And it really also depends on the logistics and setup of your institution. Is your CAT scanner 20 feet from your trauma bay? Or is your CAT scanner 2 buildings down, 3 elevator rides up and down, where there's 2 swipe cards that your nurses aren't swiped to get into, okay, because it's a different institution, and et cetera, et cetera. And believe me, we just had that when we had both of our CAT scanners went down simultaneously. Just like your refrigerator and your washing machine talk to each other, our CAT scans communicated by telepathy. That was a nightmare for 2 weeks. All right. Now, this guy doesn't need a lot of imaging, right? This guy comes into your ER, right? The only thing you need to do, this is Arizona, right? So the only thing you need to do is put your stretchers in a circle, all right, to prevent further attack, okay, right? And take this guy to the OR. Actually, for those of you who care, this is a self-inflicted crossbow bolt to the chest to transfix his heart, actually. Now, this guy doesn't need any imaging either, right? This is the perfect patient. I love seeing this patient. I mean, I don't love seeing them injured, but I love seeing this patient because I don't have to think too hard, okay? I go down to the trauma bay. I go, well, that's unsightly. That's not a pocket for your cell phone. You need to go to the operating room, right? So thank you very much for that one. No imaging needed. Now, you can stop here, right? This is a ruptured left hemidiaphragm. Your stomach should not be in your chest, right? You don't need anything more. I know some of my junior partners would be getting some more films because they got to see a lot of stuff. But again, I am old and ornery, and my compassion fatigue meter is way out there. And it's like, sir, you need an operation. I'll fix it, okay? And I'll figure out whatever else is in there when I get there, all right? Now, this guy is a little more complicated. Clearly has a chest tube. He clearly has had some problems with his abdomen. And again, how unstable is he, right? If his pressure's 50, he has some other issues. Maybe advanced imaging is not in his best interest, like death pulling. But if his pressure's 140 over 80 and his heart rate's 70, yeah, maybe he does. And I would say this guy who's not intubated and whose chest is a little asymmetric, for example, probably would benefit from advanced imaging. So again, pick your patients. All right. So what are we talking about with routine pan scanning, right? So what does it really mean? What does that word routine mean? If there's any physical finding, is it directed or is it just routine? Right? Is it based on mechanism alone? Is it just to piss off your ER guy, or to piss off the surgeon who showed up late? I'm going to get this film even though I know he hates it, right? Is it the day of the week? And really, again, how you define what routine is. What's routine to me may not be what's routine to some of the other trauma centers, okay? So it depends. The word is a very kind of, nebulous term. And of course, in our temperate trauma patients who are never intoxicated, never belligerent, and never stoned, it's, what do you do about that? Okay? Is your physical exam reliable? Right? Okay. I would say these are some of the more generally accepted indications in the patients who even are evaluable. Okay, who are awake and alert, who are not intoxicated. If you have a loss of consciousness, for head CT, if you have a loss of consciousness, or you have a significant post-traumatic amnesia, and that's not the guy who will tell you the whole story up until the time he fell out in the ambulance, but the guy may be is picked up by the medics and tells you the last road he was on, and the medics go, no, that was 6 roads ago, okay? Or the older patient on anticoagulant use. Those people need a head CT. The incidence of positive CT scan in this patient population is probably around 15 or 20, up to 20%, depending on how you do it. And that's pretty good. C-spine, most people with C-spine tenderness, yes. I'm also very liberal in scanning our older patients. And again, older is getting younger every day. All right? But I'll tell you, we just had another 88-year-old come in with absolutely no neck pain. Absolutely, you press on his neck, and he has a type 2+ odontoid fracture, and we've seen this after he tripped over the rug, and we've seen this more and more. Arizona, there's no shortage of octogenarians and septuagenarians here as well, and undoubtedly you will have the same thing, although it's very hard to find that published right now in the literature. But when you talk to all the trauma surgeons, we've all started to see this time and time again, and actually I'm very liberal in scanning older people right now. If you have a positive chest x-ray with anything on it, it's probably an indication to get a chest CT. We'll go through some of these data. And obviously a positive FAST in the hemodynamically stable patient, bruising, this, that, and the other thing. And of course the spine, how do you clear the whole axial spine? What's the best way to do that? All right? So the liberal use of head CT, okay, we've shown this, other people have. Even if you have a positive LOC, positive post-traumatic amnesia, even if your Glasgow Coma scale is 14 or 15, maybe just a little confused, and remember, a little confusion, a little perseveration, that's not really in the GCS, okay, you will have an incidence of craniotomy of 1 to 5%, depending on what it is. You'll have a fair number. Even if your scalp is degloved and you have none of this, they don't need a head CT. But if you are in anticoagulations, I think you need to be very liberal about this. But more importantly, okay, what happens is we always think about the positive, the scan that's positive. What about the scan that's positive? Well, the scan that's negative is pretty good. Because the negative scan, and we'll talk a little bit, I got questions when I gave this once before about anticoagulated patients, but if you're not anticoagulated or whatever, and your head CT is negative, and that's all you have, you can send these people home. We used to admit these people for observation all the time. In actuality, only 30% ever get observed. Usually we just feed them breakfast and make sure they're alive, okay? And this is in multiple prospective studies looking at this. And in fact, the negative study is really good, okay? And we'll talk about this a little further as we go along. Cervical spine, I think I've gone through a fair amount. There is no doubt that CT scanning is, compared to the old days when I used to try to pull the patient's arm to get C7, and they would fight me back, and then you do a swimmer's view, and I was drowning, and they were swimming, and it was just terrible, right? I mean, you just couldn't see anything. Really, at this point, in this day and age, CT scanning is the preferred modality. There's no doubt about it. And again, as I stated, in the older patients, we are starting to see a huge number of asymptomatic patients. On the other hand, the Canadian C-spine rule, the nexus criteria, not every patient who shows up in your ER to see collar needs a scan, okay? They don't, and I'm not gonna go through some of that. Well, what about the trauma chest x-ray? Again, that's still part of your ATLS protocol, right? Even though some people say you can probably get rid of it, I still think it's really important. I'm a die-hard on this one. People forget the word that it's screening, okay? It is designed to identify the couple, 3, 4, 5 things that are gonna kill a patient really quick. And yeah, maybe the EFAS can do this now. Again, I'm a bad sonographer. I will admit it publicly and on webcast, okay? And I will simply say that maybe that will replace this, maybe not. I don't know. But again, it's supine. It's suboptimal, although in a PACS you can change the contrast and really do a lot of things. But as long as you know its limitation, but when something's on that x-ray, it's darn important, okay? And you need to address this as well, okay? And again, we looked at this as well, and we'll talk about it. The most important thing is if you start scanning liberally the chest in these patients, you will change management about 1/5 to 1/4 of the time. And this number has held up for a long time, right? And the data is, and more importantly, it can be efficient, and you will change where your patient's admitted to, potentially change what your modality is. You'll find a whole bunch of stuff. Some of it's important. I will admit some of it's not. But the 1/4, 1/5 of change in management, I think, is very significant, all right? We did a study, we looked at it to see whether it would actually look at outcome, could it predict outcome? And I have both, it's the good and bad news kind of thing when you do your own research. 388 patients, they all had rib fractures. I read every one of these films myself. Thank God for PACS, okay? You'll find that their x-ray reports are really crummy. You'll find that chest x-ray misses a lot of rib fractures, no great surprise, right? And really what I was trying to do is, did it change outcome? And in fact, it didn't do anything. CT did nothing to predict respiratory failure, those patients who required intubation for more than 48 hours. It was worthless. Any finding on your chest x-ray was important. In other words, so that word screening, if it was big enough to see on the chest x-ray, it was really important, was good. And this is a nice example. This is from the study, all right? So this is a chest x-ray, which looks pretty darn good. If you really look close, you'll see that, lo and behold, there's a couple of rib fractures there. Okay, not all that displaced, right? And I've looked at this film over and over again and showed it to a lot of different people. It looks pretty good, doesn't it? Right? And here's her CT scan. It's like, darn. I went back and looked at it thinking I was just missed it, I was late, or whatever. But the lung is out to the right, and it really does. There's no stripe along the lateral border of the chest wall. And remember what the chest x-ray does, right? It takes additive densities. Pneumothorax is pretty dark, right? It's pretty black. Hemothorax, pretty white. Hemorrhage in the soft tissue, pretty white. The lung parenchyma is sort of in the middle. But when you add up all those three things, it looks pretty normal, right? So obviously she needed a chest x-ray. She needed a chest tube and her spleen out, but that's a whole other story with that one, okay? But this one is. So the chest x-ray will change, chest CT can significantly change your management. It surely changed Ms. Velez's management, okay? Well, what about your normal physical exam, you know? Well, again, I'm old and ornery, and I've been taken to a lot of people who have a normal physical exam, and when I examine them, lo and behold, the exam's not quite normal, but that's another thing. This is from Ali Salam's work, and basically they had 1,000 patients, looked at with mechanism alone in over about 60%, and you can see that, the head CT group, you can see, lo and behold, that's about what we showed, and that's what other people have shown, and the liberal CT was clearly warranted in that group. And the mechanism, specifically in the chest and abdomen, you can see that a significant number of people, quarter, had a normal chest x-ray and had significant findings. And once again, there was significant change of management done by liberal use of CT scanning. So again, even on mechanism alone, quote unquote, and again, a normal physical exam, it will change your management. And so, as much as I hate to say it, the data continues to build that more scanning is probably better than less scanning. And again, as I said, the ability to triage and manage these patients is key. This is from our work many years ago when helical CT first came out, okay? And we did head and we did abdomen patients. This is the abdominal exam. This is the abdomen, okay? And again, these are patients who are relatively normal. If you had a normal physical exam, you'd had about a 10 to 15% incidence of having a positive finding on your CT. And that number's held out pretty good. If you had any abnormality on your chest x-ray or any abnormality on your pelvic exam or any abnormality on physical exam, you double the rate. But again, the key here was not the positive so much is how it can improve your ER throughput and utilization, because we could send people home. Because this is the negative predictive value of abdominal CT. If it's rock normal, not that there's free fluid, not that there's something that looks a little funny, if it's normal or non-traumatic, they can have a renal cyst. Everyone seems to have a renal cyst these days or whatnot, right? You have and your outcome variable is the need for a subsequent laparotomy. It's 99.63%. That's pretty good. There's very few things in medicine approach 99+%. So the ability to send these people home who were not going to be observed in your observation unit, so maybe they will, or not going to be whatever, is key. And manpower, and actually now, this is long before CMS wouldn't allow you to admit people either, is a key finding. So again, your negative predictive value. Okay, This is a, again, this is a meta-analysis, came out recently. There's some issues with this meta-analysis, and it comes down to favoring whole body CT. The problem is this meta-analysis, it only has about 6 or 7 papers in it. It has 25,000 patients. Of course, 16,000 are from one study. It kind of skews the meta-analysis. I'm not certain statistically that's actually even accurate, but it does go down and does predict a little bit about that whole body CT, liberal use whole body CT is actually beneficial. Okay, cost, right? You gotta have, come on. And this has been shown, a significant amount of our healthcare dollars are now have been in imaging. There's no doubt. That's why I want to own a CT scanner. That Stark thing doesn't allow me to do, but whatever, okay? Is it really costly? And this is another analysis of this. And again, you got to be very careful with healthcare economics. That's a whole other talk, and it's a whole other, I'm not certain there's science there. There's a lot of mystery in that. But it depends on what you put in your model, right? Do you put the nurse's time? Do you put the resident's time? Do you put this? Do you put that? Are you going to fire, if you don't do the CT, you're going to fire the CT tech? Are you going to sell it on eBay? There's a lot of issues there, right? Ultimately, actually, if you look at efficiency and whatever, it's clearly not more costly, and it may actually be cost saving. Again, different pots of money, and you have to be very careful about the economics. And of course, when no talk about imaging would be, free of, well, what about the radiation risk? Okay? Again, another complex and whole other talk. So this is from one of the commissions on radiation. And I will say basically they come down to the fact that how much radiation people get from medical imaging is a very unclear science. I am not advocating extra scans for people who don't need it. I'm clearly not advocating willy-nilly scanning children. I think that's a big group that's a problem. I think you need pediatric protocols. For example, it drives me crazy in my center for maxillofacial CT. I use the head CT to screen it. Almost no one ever needs a maxillofacial CT unless their face is completely smashed in, and my colleagues need it for planning reconstruction. Most of them don't. It drives me crazy to see an isolated maxillary sinus fracture or diagnosing a nasal bone fracture with a dedicated head maxillofacial CT. So we've tried to limit that. And again, I'm talking about these per se. Okay, what about the unstable patient or the metastable patient? And we talked about that during Dr. Ree's case. Can the guy go to CAT scan? Can the guy not go to CAT scan? And again, a little bit goes with your resources, where your CT scanner is. We've all, I think, taken patients that we've rued the day we've taken them to CT scan. I can't tell you how many people I've intubated in the scanner, and I'm too big and not flexible enough any longer. I need to do more yoga, Rick, to get in the CT scanner to intubate someone anymore. But it's a problem, right? Again, going back to this patient, well, how unstable is he? All right, and again, there's a rule in our place that the residents have coined: the cooler the x-ray, the less likely you should be to look at it. Now, in the old days, for those of us who predate digital x-ray, as an intern, if you got a bad x-ray, you could throw it in the garbage and your chief would never see that pneumothorax or whatever, right? Come on, we've all done it, right? Okay. Now, digital radiology is like emails or text. They're forever, okay? So you really shouldn't see this CT scan, right? Probably a tension hemothorax? No, I don't think so. And this one, I love this one. This is not my place. Thank you very much. It was sent to me by a colleague. If you need a CT scan to get this one, I think there's a problem, right? So, 2 minutes, I'm just about done. So when you push this envelope, this is this study that I told you that we screwed up the meta-analysis with 16,000 patients, right? It's from Germany. It's really pretty good. They really scan a lot of people. It's a very good paper and a very well done study for a retrospective data mining kind of thing. And they really did pretty good. And you get to this point where they took some people with some marginal blood pressure to CAT scan, And I will say that in almost all groups, you can see that liberal use of CT scanning, whole body CT scanning, resulted in decreased mortality. And even in the group that was marginal, I don't highlight that group, they just hit the p less than 0.05. It always makes me nervous when someone gives me a p-value of 0.049. You know, they somehow managed to wave their hands and get that one. And again, when you risk stratified it, it worked out as well. So in summary, I really think that the data does come down that liberal use of CT scanning, okay, appropriate CT scanning is probably better than trying to figure out which one or missing things, all right? I think it will improve survival, it'll improve optimal management, it'll allow you to get people out of your ER whose scans are negative. And I think that its radiation and cost profile is really pretty good. So I want to thank you all for your attention before lunch.